Afternoon. Welcome to the Dr Steevens Hospital press briefing. Could I ask the speakers first to introduce themselves from the left?
Sure. Damien McCallion, HSE National Lead, Testing, Tracing and Vaccinations.
Colin Henry, Chief Clinical Officer, HSE.
Paul Reid, CEO, HSE.
And I'm Mark Brannock, the National Director of Communications. And can I welcome Bernie and Margaret, our Irish Sign Language interpreters. This briefing is being broadcast on the RTE News channel and on the HSE Live Twitter feed. And can I ask Paul Reid first to give his weekly update?
Good afternoon, everybody. Thanks, Mark. And there's no doubt from a HSE perspective, we do go into the Christmas and New Year period with a sense of hope, but equally measured with a high level of uncertainty. And the hope certainly relates to the fact that we have seen over the past 2 weeks in particular, the hospitalisations from COVID stabilise to a level, albeit at a very high level, and also on ICU. And I guess the hope is related to the immediate and early benefits that we are seeing from the vaccination programme as it's been administered, and particularly it's been administered to the more vulnerable groups. The uncertainty obviously relates to the unknown as we await further real-world evidence in relation to the potential impacts on hospitalisations and illness related to Omicron variant. And the uncertainty that would bring or brings to us, particularly as we head into the Christmas period, if we do sustain at those high levels of hospitalisations at the moment. But ultimately, hope in itself isn't a plan, and we will be continuing with the actions that we've put in place over the previous 2 weeks to de-escalate the risk in some of our hospitals in particular, but all across our health system. And certainly the actions that the public have taken, we do know have proven hugely beneficial for us in terms of reducing the impacts on hospitalisations. They are working overall. And as I have said before, the strongest first line of defence are those actions that the public are taking, public health actions, and they are making a difference, and we continue to be grateful for them for doing that. Along with this, however, equally strengthens our first line defence are the take-up of the vaccination boosters and the third vaccine doses for the immunocompromised. We now have over 977,000 boosters and 95,000 additional doses administered, so a total of over 1,070,000 in total between the boosters and the third vaccine dose administered. And even the better news related to all of that is that well over that million now is highly concentrated, which we know are the more vulnerable groups, and equally good news to the extent that we are seeing the case levels reducing in those groups that we have administered booster to date. And we do still remain in the top 4 in Europe in terms of administrations per 100,000 of the booster programme through to population. Just in terms of our continued message about the need to take up the booster, and I think it's been strengthened this week in terms of the rationale as to why we are urging everybody to take forward and come forward and take the booster. And it's very clear that the primary vaccination has provided very good protection against hospitalisation and severe illness. But we do know that that protection does wane after a period of time. And the booster dose so not only reverses the waning effect, but also leads to an enhanced level of protection, as well as longer lasting protections compared with the original vaccine doses themselves. While we're still learning about the new variant, Omicron, experts do agree that the current vaccines will represent our best form of protection against Omicron. And I just cite yesterday's, as an example, the statement by Pfizer-BioNTech indicating that 3 doses of Pfizer leads to a 25-fold increase in antibody levels against Omicron compared to just 2 doses. And for people wondering whether they should wait with a potential for a further vaccine emerging for Omicron specific, the advice from all medical experts all across the world are saying don't wait. So there are a number of reasons that I would just re-emphasise for the need for everybody to come forward and take the booster shot. Firstly, as I've just said, it does provide a much increase and indeed a longer lasting protection against the current dominant Delta variant dominant. For now, it's definitely our best form of protection against Omicron. And there was a very strong case for boosters initially, and it's certainly more evidence has proven it. with the Omicron variant. We know and well reported that we've had a number of issues regarding multiple contacts and appointments and frustration that has caused for people. We have, as my colleagues have been outlining throughout the day, a number of actions that we have taken to alleviate some of those issues. We know there's a range of reasons why we may be offering some multiple appointments. But equally, there have been occasions also where people may have had previous infection of COVID within the last short period of time and not coming forward, and may in some cases not notify us. So we have put in place some revised text messages that go out, which give people an option, 3 options. 1, rejecting the option of the vaccine for various reasons. Secondly, seeking a new appointment, or thirdly, indicating a COVID infection. And we can then act on the responses that we get from those texts. But certainly what we are seeing, and our decision to bring forward further people in the population, so as of today, those in the over 50s, we do know that it's driving further and further demand. Now, as we've seen today throughout the country, more people coming forward, particularly for walk-in centres. Just the other kind of points I just want to make on it is the recent NIAC recommendations that we've got. We'll take some questions on this later. We received the NIAC recommendation, as you'll be familiar, which set out the prioritisation process around the 5 to 11-year-olds. There's some specific recommendations related to particularly 5 to 11-year-olds with immunocompromised or living with people who may be medically vulnerable. And they're quite complex in terms of the identification of these groupings within the 5 to 11-year-olds. And we're currently reviewing this at this point in time in terms of how we would operationalise that. But the one thing that we don't want to compromise is the pace and speed of rollout. And we do know in previous occasions where we were rolling through medically vulnerable groups, when we moved to ages and rolling through ages, we were able to move at pace. So we are reviewing the recommendation. We are assessing the operational implementation of it, but one thing we want to ensure we don't compromise is pace and speed. There's also some emerging good evidence actually recently just in terms of the healthcare workers, and they taking up their boosters obviously in quite strong numbers. For the first time, we've seen a small reduction in the numbers of healthcare workers who are out for a period of time. It was around 5,800. It's down just marginally to 5,500, but we would expect to see that come down, hopefully significantly over the coming weeks and giving us some relief. We've particularly seen it come down in good relief amongst frontline healthcare workers in particular. Very briefly on our hospitalisations and ICU, we're at 532 positive COVID patients in hospital today and 115 as of just lunchtime in ICU. We'd really like to see a trend continue. We seem to be kind of stuck around that 500, 550 figure. It does drop on occasions, but climbs back up again. So it is still far too high a base for hospitals as we head into the winter period, and particularly that we still have practically 40% of our ICU beds with COVID positive patients. And we do know we still have to plan, as I said in my opening comments, for the Omicron variant and what that may pose for us. Unvaccinated in hospital and ICU, I give you the weekly figures, but just to say again, this is a highly, highly disproportionate impact on our hospital and our healthcare system. Today, 49% of COVID patients are not fully vaccinated in hospital. In ICU, it's 52% with no vaccination at all and 2% partially vaccinated. So again, a call to people, please come forward. There are many opportunities to protect yourself, your family and wider society. The number of patients confirmed with COVID, as I mentioned, is down about 8% compared to last week. In the past 7 days, there have been 316 admissions of COVID patients to hospital. And in the past 14 days, 545 have been hospitalised. Of those 545, just about 11% are in the ages 0 to 18, 12% 19 to 34, 41% in the ages 35 to 64, and 36% in the ages 65 and over. Finally, on testing, my colleague will give you some figures again just on testing, but we continue to see a really high demand come forward for PCR, ultimately PCR testing of 220,000 per week. So seeing well over 1.1 million in a 5-week period. And we've taken a range of actions which we've outlined before, including procurement of further private capacity, and we do intend to build that slightly further again between now and the end of the year. But again, we make the point, it's not an endless resource that we can put into this. Finally, my colleague Anna Connor isn't here today, apologies, but just to say we are still seeing significant demand on our hospitals overall, even throughout actually, and our emergency attendances throughout Storm Barter, we still saw high attendances overall, particularly over the past week. High attendances and admissions for those aged over 75 years of age is actually, for last week, above the equivalent week in 2019. And just drawing the equation, the equivalence of what was happening in 2019, we had at a peak of our flu season, and we're not at a flu season, we're not at a peak, any peak by any stretch of flu season at the minute. So that is a cause of concern for us. We are putting in place, strengthening any actions we can to support people at home and getting care, not in the hospitals, but certainly for those aged 75 years of age, we did see a higher demand. I'm going to pass you across to my colleague, Dr Colin Henry.
Thank you. Just want to update you on the current disease trajectory and the impact of the Omicron variant. So we can see here, beginning of the 14-day instance, we're at 1,360 per 100,000 population, slightly up, and our 5-day moving average is 4,690. It's up 5% on last week. And compared to that peak in January, of course, at that time it was associated with a much greater degree of conversion to harm in the form of hospitalisation or people admitted to ICU. And the total number of COVID patients in hospital, 543, is kind of a steadying rather than a greater fall we would like to have seen. And ICU, again, a kind of steadying, and there's ongoing pressure, particularly in the critical care units with despite all the resources we're putting into it, the additional capacity, we see limited bed availability as a consequence of this and other seasonal pressures that we're seeing. Looking at the new case in COVID has risen in the month of November from weekly average, just at the beginning, 1,493 per day to that level now at 4,717. That graph at the top shows that levelling off that we're seeing in the past week. December the 8th, similarly, that hospitalisation, despite some of a promising fall there a week or two ago, it seems to have levelled off, and ICU likewise. This graph illustrates the increasing hopeful signs and shoots of the impact of the booster campaign in older people. And you can see that the number of cases that we've seen in that 2-week period from the 24th of November to the 7th of December in the over 65s has fallen slightly again. And this is happening week on week and now constitutes 5.7% of total cases. And we've seen this fall week on week from a proportion where it was 9, 10 or even higher percentage of cases were in the over 65. It's now 5.7% of cases. And it's very, the most obvious explanation for this is the protection afforded by the booster vaccination program. Of course, it was rolled out in the older age group first, beginning in residential care settings and those over 80s, both settings of which are now substantially complete. And we see that left shift where the fall in, if you look at that bottom table, you can see the fall in numbers of cases in all those older age groups, and the only age group really rising significantly is the 0 to 18 age group rise of 9.9% over that time period. Outbreaks, relatively, when you consider the degree of cases in the community, the level of transmission in the community, the outbreaks remain, thankfully, to a large degree controlled, and that's thanks to huge work and the constant diligence of staff there in trying to maintain infection prevention control measures and trying to avoid transmission and doing everything they can to protect the people who they care for and of course the services that they're in. And nursing homes, 10 outbreaks in that past week. Community hospitals 5, acute hospitals 10, and we're seeing a drop in the number of acute healthcare workers. And we did peak, if you remember, That weekly number of healthcare workers with COVID up just over 500 a few weeks ago. It's now fallen to just below 200. That's an encouraging sign. Likewise, residential care institutions of other types, 26 outbreaks. So the Omicron, which now update as of most recent, is if you look at the ECDC most recent update, December the 8th, they looked at the big criteria against which we measure whether or not we should be worried about this and what the implications will be for ourselves, healthcare, and for those who are vulnerable. And that's transmissibility, the effectiveness of the vaccine, the risk of reinfection, and any other properties of the variant. And because there is considerable uncertainty surrounding these factors still. And at that time of the report yesterday, they noted 337 cases in the EU, EEA, number of further probable cases, most of whom had a link to a history of travel to African countries. What's emerging, which we'd expect to see, is some cases that don't have a link and represent onward transmission. The WHO had their update December the 7th, looking at those, again, those big criteria. Transmissibility remains unknown, but Omicron variant appears to have a growth advantage, and they forecast it could become the dominant variant in Europe by the 1st of January 2022. Disease severity, some early indications, and you'll have heard Dr. Fauci and others comment on this, and the data coming from South Africa, I'll show you shortly, is while hospital admissions increased greatly in South Africa from what were a low base, the profile of cases to date has been somewhat less severe than that seen in the EU. The effectiveness of vaccines, there's lots of work underway, operating at speed to look at those mutations that have been identified in the spike protein and are perhaps a proxy for resistance to vaccine. Is that replicated in real life? And there's huge work going on internationally to demonstrate whether or not this is the case. Effectiveness of current tests or PCR and antigen tests continue to detect infection. And effectiveness of current treatments, it's expected that the treatments that we use, especially in those severe cases, remain as effective as they were before. The UK Health Security Agency, which really encompasses public health, have looked again at implications of the UK, where there's now well over 300 or more cases. Transmissibility between humans, amber level, based on the evidence from South Africa I've mentioned. The impact of this variant on naturally acquired immunity at red level, because only those mutations do suggest reduced protection from natural immunity, and likewise those mutations suggest reduced protection from vaccine-induced immunity. So they've coded those, the status of the variant as red in those domains. So South Africa, we can see, if you look at these graphs, they look at a different trajectory of the successive waves of COVID-19 in South Africa. The green wave is, the first wave is a blue wave, second is the green, third is the purple, and the fourth is the most recent due to Omicron. And you can see a surge in case numbers suggesting this variant is more transmissible than previous variants and will displace it. And this trend continues. It is expected to displace Delta as the dominant variant in South Africa. The proportion of cases returning positive in South Africa has risen from 10.3% on the 30th of November to 24.3% on the 3rd of December. This case in the Shawani district, I hope the pronunciation correct, in South Africa, which is the epicenter of the outbreak, so to speak, has seen cases rise exponentially, and they've looked already, though it's early days, on the experience of disease severity. And of those presenting, 70% of COVID positive cases were not oxygen dependent, 80% of admissions were under 50. It is a relatively younger population, and vaccine uptake in that country was at a lower level than ours. The length of stay was 2.8 days, much lower than the average length of stay of 8.5 days. And 6.6% of those admitted in the past 2 weeks have died. But while there are some encouraging early signs in terms of disease severity, it's too early to draw definitive conclusions. Some early lab research, again, small numbers on study participants in South Africa, suggests that it has some potential to escape immunity induced by the Pfizer vaccine with this drop in antibody levels. And it's been quoted, you may have seen, a large fold drop in the ability of antibodies to neutralize this variant compared with the original virus. But what that means in clinical terms, because that doesn't mean that huge drop in antibodies doesn't necessarily reflect the clinical response and how more vulnerable you are. So I'll show that shortly. So it is a proxy perhaps for, it's obviously one measure of one aspect of the immune response, but it doesn't tell us enough yet about the clinical response. So looking at vaccines and immune response, there's preliminary lab studies show that 3 doses of the Pfizer vaccine have the capacity to neutralize the Omicron variant, while 2 show significant reduced neutralization levels. The levels after the booster dose compared to levels observed after 2 doses against the wild-type virus, the original one, show a high level of protection. And these findings suggest a booster dose is required and should provide sufficient protection against the Omicron variant. Again, this is early study, but it's encouraging. And this graph here shows you the kind of illustration of the different types of immune protection we have. That is those neutralizing antibodies we hear so much about. They're induced by the vaccine that protect against symptomatic infection, but they wane, and hence we see more infection in recent months as the effect of those vaccines wane. But it's the other less measurable responses, the T cell responses, which protect against more so against severe illness. And that's why we see that despite the waning of antibodies, we see a persistent protection against serious illness in the 2-dose vaccines, but which should undergo some degree of enhancement now with the booster dose. The variants around the world, this map is beginning to heat up now and colour up with detection 20 states in the US, Canada, and obviously the south of Africa, Indian subcontinent, Europe, Russia, Australia, and we expect to see onward transmission in those countries. So looking to Ireland to go again to the unvaccinated population, if you look at the experience over the past 2 weeks, of all cases identified, unvaccinated individuals constitute about 13% of total positive cases, but they account for 46% of ICU admissions. So people who are unvaccinated are much more likely, if they acquire infection, they're much more likely to acquire infection, first of all. And once they acquire infection, they're much more likely to become seriously ill, whether it's hospitalization or even admission to ICU. So it's not just the vulnerability unvaccinated people have in acquiring what is an extremely transmissible virus anyhow, and we're now facing an even more transmissible version of that. But once you acquire that, we've known in its natural state from last year that when we didn't have any vaccines, that the conversion rate, once people acquired the infection, there was a much higher rate of hospitalization and oxygen dependency in ICU, much compared to flu or any other cases, a much more severe disease. And that remains the case for unvaccinated people. There's no additional protection they have because 95% of the adult population are vaccinated. They remain every bit as exposed to acquiring the virus, becoming infected, and becoming sick once that happens. And this illustrates this. If you look on the left, we often talk, people ask us, and I think some of the colleagues here in the room have asked us before, but the conversion rate of the numbers of cases to hospitalization, and we talk during the peak, for every 1,000 cases we had, there were 55 hospitalized, and that fell to 25. But of course, that's a round table figure. It doesn't differentiate between those who are vaccinated and those who are unvaccinated. And this graph on the left shows that for those who are unvaccinated, the yellow line, much higher rate of conversion to hospitalization compared to those who are fully vaccinated in the blue line. So when we talk and the questions are put to us, what is the conversion rate? How many are hospitalized for every 1,000? That includes everybody. But there's a difference, and not just in terms of risk and age, but in terms of vaccinated. Perhaps the greatest difference is in between those who are vaccinated and unvaccinated. And ICU, again, a huge difference per 100,000. If you look at that difference in that blue line at the bottom, the very low risk of ICU admission for those who are fully vaccinated versus the very high risk in the yellow line for those who are unvaccinated. The link between cases and deaths, we can never say it's broken, but if you look at that orange surge is deaths in surge 1 and surge 2 in January, but it's hidden behind the green, the surge in cases laterally. So surge in cases laterally, and this is what we call this fourth surge, is hiding behind it is a much lower rate of cases that have died, which reinforces that message that despite the disappointment over the drop in antibodies and perhaps waning immunity, is that the protection against serious illness remains quite substantial. And likewise in hospitalization, again, look at those 4 surges, with the second one being a small one, the biggest to date being in January with that very tall peak. But again, on the right-hand side, that light blue, the number of cases, dwarfs the numbers who are hospitalized in ICU, unlike January when we saw that steady, predictable, very hard to accept conversion of cases through to hospitalization. Again, positive news here. We see the positive of boosters for the elderly. If you look here at those 2 dotted lines going down left-hand side, the booster shots begin for the 80 plus The right-hand side dotted line is the booster shots begin for the 60 pluses. But look at that purple line of those age 85 and over begins to level out and then drop. And likewise, the 75 and 84s a little bit later. And the others, they will go the same way. There's no reason not to expect that what we see here will happens in other countries such as Israel, who are earlier on this line, that we'll see that drop. And likewise, the hospitalisation numbers again, look at the figure, look at that purple line for 85 pluses after they began the booster a rise and then levelling off and then falling. And again, an encouraging sign that these do work in terms of reduced cases, but more importantly, in reduced hospitalisation. For fully vaccination, 18 plus year olds, we remain up there at approaching 94%. The booster, Damien will talk to that shortly, really has, there's been a lot of talk this week of people not turning up and multiple appointments, but it's getting there. It's reaching the groups that are most important. That's 85% of the over 80s, 80% of those in their 70s. We're getting there now that we've crossed eligibility thresholds of the 69s, residential care facilities for younger age groups. For older age groups is more or less done. That refers to those with younger age groups. Healthcare workers now over 2/3 done. Immunocompromised 85%. And these are the groups that are overly represented when it comes to getting sick. Nearly finally now, Omicron, lots of uncertainty, of course, and it's certainly looking at the best versus worst case scenario. It certainly seems more likely to be more transmissible. It seems there's lots of work being done on the vaccination. Are they effective? Some suggestion that an additional booster dose coming out from Pfizer may afford more protection. Some suggestions in terms of disease severity, it may be less, but it's too early to say. And in terms of therapy, too early to say whether the existing therapies we use are any more or less effective. Messages, I'm afraid that uncertainty remains a key message, and I can't fix that. It's hard to, in the absence of information that we need, but there's so much work being done right across the world to try and understand the implication of this new variant. Or in terms of where we are at home, our healthcare services remain under pressure. And of course, that steadying in case numbers, the steadying in hospitalizations means we're under a constant level of pressure trying to deliver all the other services we're trying to do at the same time. Unvaccinated people, I've shown you, I hope today, illustrated for them the risk that they're carrying in terms of becoming infected and becoming ill, much more so than people who are vaccinated. And once they get infected, they're much more likely to get sick. Vaccinations alone will not control case numbers. Those public health measures of reducing contacts, mask wearing remain critical. The waning of immunity necessitates booster campaign, as we're underway now. And as we've said many times, prevention of infection in the first place through all those measures, vaccination, the public health measures, and everything that's been asked of a very patient public is much easier than treatment. So thank you. I'll pass you now over to Damien McCallion, the head of the vaccination programme.
Thanks, Colin. So I'm just going to quickly on the testing side first, just to give people a flavour, recap of where we're at. By the end of November, we've increased the capacity from the 100,000 bar to 224,000. And our aim, and we're on track by the end of December, is to increase that further to 245,000. So we're still seeing increasing numbers coming through, over 1 million in actually less than 6 weeks now in terms of a running cycle. And over 200,000 swabs per week. And the testing system, we are seeing an improvement in terms of access for people from a number of perspectives. We're releasing more slots during the day. I've mentioned previously that what we do is, as the centres see what the attendance rates are, they will release further slots. And they also look at the clinical priorities, those from general practice and close contacts. And again, certainly in the early part of this week prior to the storm, we were seeing much more accessibility to those slots through the locations. Just then some headlines, and I'm not going to go through all of the numbers. The storm did have an effect in the sense that some of our centres had to close down due to the weather storms on Tuesday and in Wednesday in some areas. And those people are all been rescheduled as quickly as possible. And all of the centres have tried to do things such as increasing staff hours and so on. People have come in, and I just want to acknowledge the support of our staff in the testing centres who've worked really hard to try and get people back on track. Again, November the 30th remains our busiest day in terms of the community testing side. And always bear in mind that our acute hospitals are running close to 5,000 additional tests per day on any given day of the week. So last week, 3 new testing centres commenced operations, 1 in Athlone, 1 in Leopardstown and 1 in Swords. And these are on top of 3 sites which opened in previous weeks, all of which are also increasing their capacity that are available for testing. In addition, our pop-up testing centres, we've increased those significantly in recent weeks through some partnership work between our ambulance service and other providers. And last week, and remember, the pop-up sites go into an area for a period of time where we see pressure and allow that pressure to be alleviated and then move to other locations. So places like Youghal, Carlow, Ballinasloe, Dundalk, Wicklow and Kildare all had increased capacity over that period. So while demand is high, we continue to monitor that. And again, as I say, we had some very positive signs pre the storm, and we'll continue to try and look at opportunities to do that. Last thing I want to get across is our antigen programs, public health programs have been running for some time now. So for those close contacts, these are vaccinated, asymptomatic close contacts who get the test kits. Over 125,000 kits have been dispersed. And in terms of our primary school pods, just a recent initiative, over 40,000 kits dispersed. So just in general, on the performance side, we're still seeing good turnaround in terms of the time from when someone, the end-to-end time in terms of turnaround time for both positive detected and not detected results. And again, some numbers there. And as you can see, the laboratory tests continue to run at very high levels for PCR. Moving on then to our vaccination programme. Again, just Colm has touched on this in terms of the primary vaccination programme, and given the points that Paul and Colm have made about the risk for people who are unvaccinated, we continue, notwithstanding the focus on the booster programme, we have an uptake improvement team who are looking at all sorts of initiatives across areas. And last week, still 18,000 people took either their dose 1 or dose 2, and that's really impressive. We hadn't anticipated we'd be continuing to see those numbers coming through, given the passage of time since the main focus of the primary vaccination programme. And you can see that we're over the 93% in terms of the full adult population and 95% in terms of those that are partially vaccinated. So we continue to see work there. And again, it isn't really about the numbers. Many of these are in at-risk groups where we're trying to focus to make sure some of the slides that Colm showed, those are the people that are most exposed in relation to hospitalisation and ICU. So again, moving to our booster programme, Paul touched on where we are in Colm in relation to European terms. Interesting of note, the 2 countries that lead would have received their advice way back in August and commenced their programmes. So in overall, I suppose, terms of where we're at relative to Europe, we're doing really well in terms of hitting the million and going over that. And obviously our focus at the moment is to try and increase the uptake and improve not just the position, it isn't about league tables, but to make sure, I suppose, that we get the maximum number of people vaccinated. So just briefly, and I won't go through all the numbers here, just where we're at, long-term residential care was substantially completed for the over 65s, which was the initial advice from NIAC, close to 1,000 facilities. We then had to visit all facilities to do those under 60, between 60 and 65, and we're now completing out following the recent advice on all of those 60 and under. These are residents who might be in these homes who are under 60 years of age. The over 80s, the GPs are substantially complete. We have a home vaccination service, which I'll touch on as well in a moment. And again, some records still flowing through there, but general practice are happy that they're hitting through the vast majority of those. 70 to 79, again, been worked through GPs, substantially completing this week. Again, really good work through general practice. And again, encouraging maybe those final people to come forward talking to GPs. We would like to see that just those final people that would come forward for their vaccine in terms of the 70-year-olds. 60 to 69s, working through the vaccination centres. Again, many of these are only becoming eligible through recent weeks. So they again are getting offers in terms of vaccination through appointment, or indeed availing of a walk-in, be it through the vaccination centre or through our pharmacy sector. Housebound, which I touched on, and again, this is a really important service, some of the most vulnerable people, initially there for older people 80 plus, now extended to 60 plus, 780 people. And I've mentioned before, we have any 2 people that vaccinate on a given day may only get to visit 6 to 7 people. So while it's resource intensive, it's a really important service for those people who are at home. Healthcare workers, again, substantial progress through that. Some of those will hit eligibility as well, but the majority of those, again, our aim is to have all of those completed over the coming weeks, and really good progress there with opportunities for people as well to avail of walk-ins or indeed the pharmacy. Medically vulnerable has only recently commenced and close to 100,000 administered. Majority of those eligible, again, the aim is that they will be dealt with before the end of December. And again, the 50 to 59s is just commencing. GPs commencing this week. And GPs will actually issue appointments to people. They will contact their own patients. There's no need for people to contact them. And the vaccination centres will contact people, or indeed people have the opportunity around the walk-ins into vaccine centres or pharmacies. So in summary, close to 1.1 million doses administered across both the booster and the immunocompromised. Ireland, again, is doing very well in European terms, with the majority of the countries that are ahead of us at the moment having commenced their programme earlier. Again, to recap, and it's really important, we continue to work through those at-risk cohorts. And column slide that showed the impact on the hospitals of those people. They are the people who are at greatest risk, and that's where our current focus is. Significant progress across the groups that I've covered. And again, we're increasing the vaccination channel capacity across general practice, our vaccine centres, and our pharmacies, who are continuing to increase their activity week on week. We know there's been some challenges around the appointment scheduling, and we apologise to people who maybe have been impacted by that. But I just want to reassure as well that in terms of our GP and pharmacy systems, those are feeding the information through pharmacy on a real-time basis and GPs on a daily basis. And just to clarify that point, I think that may have come up this morning. And similarly then, in terms of looking forward, we're continuing to plan through the recent NIAC groups where we got authorisation to proceed with younger age groups, and also in terms of the children's programme, the 5 to 11, where we received the advice yesterday afternoon. Thank you.
Thanks very much, Damien. I'm now going to take some questions, and could you give your name and media organisation, please, Fergal?
Good afternoon, Fergal Bowers, RTE News. I suppose the one thing that's missing from today's briefing, and we haven't heard since a week ago, is Omicron in Ireland. I mean, all that we've been told so far is that there's been one confirmed case. I mean, have there been more confirmed cases? Because up to about an hour ago, 817 Omicron cases in the UK. So what's the situation in Ireland regarding Omicron? How many confirmed cases to date?
There's just one. Clearly, there's investigation of any of these S gene dropout cases. That's a marker for it, and they require whole genomic sequencing to confirm. So there's a number of cases being investigated at present who have S gene dropout, and those results are awaited.
We know we're going to see significantly more. We're going to see it rise, and all expectations, it becomes dominant. But the timing of that is uncertain at this stage. But we will be planning on it becoming more dominant.
In relation to the no-shows, I mean, it wasn't particularly out of the HSE. It seemed to came through the political system. There was quite a lot of criticism, really, of people not showing. I mean, huge numbers. The suggestion was that tens of thousands of people weren't turning up, and there were no shows. And wouldn't you accept that in the main, it's not the case that it's anyone's fault, any person's fault? It's that certainly there's been difficulties in the ITN, certainly. Some people did have difficulty cancelling an appointment if they'd already got a booster jab. And you look at the numbers at UCD this morning, 600 people turned up, and they could only accommodate 100 an hour. So, from 8 to 11, they run the walk-ins and then had to send quite a large number of people home. And then the Croke Park Centre totally booked the capacity this morning and this afternoon. Doesn't that show people's huge enthusiasm for uptake of the booster campaign? But does it raise questions about capacity of the HC to deliver on the demand now?
I can take just a couple of comments, and then I'll ask Damien, who's been leading all this. Just first of all, we know from the enthusiasm in the first and second doses, it will continue and has continued into, as Damien said, now 1.1 million of the population taken up. Secondly, I don't think the Taoiseach or any of us were setting out to blame that the public weren't coming forward, but you have to stand back and just look. Certainly, we were seeing, through some of our walk-in centres, not the same take-up over the previous 2 weeks that we might have thought. And indeed, talking to some of our GPs in the ICGP, they would have not seen the same demand at some stages that they might have thought. So we do want to encourage people to come forward, that's for sure. There are a few differences between the way we're managing it this phase versus the last phase. So versus the first 2 doses. So for example, we have multiple channels now for people to go to. In the first phase, it was dedicated channels. You had your GP or you go to a vaccination centre. Now it's open to 3 channels to people. So that is a big difference. The second difference is being, as we're working through the ages now, we're going through the ages in bigger blocks. the last time we were going down 59, 58, 57. So that's all geared towards bringing more people through quicker with what the concerns we have with Omicron. And then the third difference would be, in the first phase, we went largely with appointment-driven processes. And then at the tail end of each age, we went with some walk-ins. Whereas now we've gone from the start with walk-ins. So, for example, this morning, a high level of demand, certainly in UCD. On capacity, we're increasing our capacity throughout. And we've said it out before that we are both in our vaccination centres. Pharmacies are taking up much more. It's a high demand for them in Christmas. And GPs have done a phenomenal job. So yes, we're strengthening capacity, but there are very big differences the way we're doing it this time. And yes, there's been issues that has caused.
Yeah, and just to add to what Paul said there, I mean, one, I want to reiterate that effectively, look, our objective here is to try and vaccinate as many people as possible and to give people that opportunity to get vaccinated. We've seen the numbers, 217,000 people last week. You know, we know in terms of European terms, we're doing really well in terms of the numbers we're getting through, Fergal, and we want to continue with that. And what I would say then in terms of adjusting the strategy, one of the reasons actually is we saw in the morning time, for example, we weren't necessarily getting the throughput in the morning. And we understand people have more commitments. We're entering into a really busy period coming into Christmas. So one of the reasons I suppose we wanted to stimulate that discussion was to try and encourage people to try and take that opportunity first time, because it allows us to increase the activity to get to more people quicker. And secondly, adjusting the strategy on the walk-ins. While we don't want anyone to have to queue for excessive periods, there were 22 walk-ins this morning and running throughout the country today. And on average, you know, looking across the country on our social media channels, we're keeping people up to date with waiting times so they can see if there's a long wait, they can make a decision maybe to go to another centre, defer to another day, to make it as easy as possible for people around that. So given that we've just introduced this in terms of the 50s, look, we did anticipate some issues and we'll work to tease those through. But overall, UCD this morning would have done close to 50 to 75% more this morning than they would have done on other mornings previously. So we want to try and increase the capacity in terms of the number of people getting through. But at the moment, capacity isn't our challenge. Clearly, in terms of this morning in that queue in UCD, we don't want people to have to not be able to get through in that. And we look at how we can maybe smarten that up or improve it. But overall, it will allow more people to get vaccinated more quickly, having that mix of options for people between appointments and walk-in. And that's our ultimate objective, to do it in as smooth a way as possible for people as well. Bearing in mind also the pharmacy sector also would facilitate appointments for people where possible. They'll have a more limited capacity in certain areas in the country. And all the eligible pharmacists are listed on hse.ie. And in parallel with that, then the GPs on an appointment basis, they're calling their own patients and working through the priority groups as well. So, you know, there are a number of ways in which people can get vaccinated, and that's our objective with the booster programme, which is slightly different, as Paul said, where we work through the other groups methodically in the primary programme.
I'm sure this is probably for Damien McCallion also too, just in relation to the vaccination programme for the 5 to 11-year-olds. How are you going to deliver that? Will you, obviously the NIAC asked you to look at having special child-friendly clinics. But might you do it through schools? Might you do it through the vaccination centres? Might it be a mix of GPs and pharmacists? It's a complex vaccination programme, there's no doubt about that. There's so many elements to it when you look at it, and none of these people are registered yet. And you have registration details of all the others groups, but this will be a first-time registration. So have you nailed down how you'll deliver it? And just on the end of that, do you expect some of those vaccinations, you know, this side of Christmas, but most of them January and over several months?
Just talk about some of the elements that make that up first, and then Colin might talk to some of the wider challenges. I suppose, you know, we've received the advice yesterday. So we've had a project team stood up for some while, and the areas we look at are the operational model, like you described, what's the best way to deliver it, the public information campaign that's needed, particularly for young children now to support parents, the medical guidance that's needed in relation to operating the vaccines, the actual guidance around the pharmaceutical side, because it's a different vaccine, as we know, in terms of how it's handled, the logistics and distribution, the communications plan. So all of those elements and the IT system changes that are needed to facilitate this have been worked on over the last month or so. I suppose what we'll do now that we've gotten the advice from an operational perspective, we'll link in with our clinical group, and Colin will talk to some of the challenges around that in a second, and then we'll decide what's the optimal way to deliver. But all of those pieces have been worked up in parallel so that when we actually do get through, we'll be able to commence then with all of the elements in place. And I think particularly for young children and parents, it's going to be really important that the public information is good. And if you go back to the primary programme, one of the successes was that we made information available to people, really good information. And, you know, I would say that's one of the reasons the uptake, people responded to that, not just in terms of campaigns, but in terms of all the work that all of our clinicians did, the professional bodies, and so on as well. But I might ask Colin to talk to the letter and the advice.
Just briefly, thanks, Damien. So if you look at the letter and the recommendations, there are two groups. One for whom the vaccine is strongly recommended, and that is to say those with underlying conditions, those living with a younger child with complex medical needs, and those living with a person who's immunocompromised. And then for the remaining population, 5 and 11, who are children, it's to be offered, which is a different grade of advice. And so we have convened, we know there's been a great amount of preparation by our National Immunisation Office, who have long experience in childhood vaccination programmes, led by Dr Lucy Jessup. They've been working in anticipation long before the letter came from NIAC yesterday. They've been working in anticipation of the EMA approval and the NIAC letter in how best to administer the vaccine, what settings to administer it, how to communicate with parents, what information to give, and this was all anticipatory planning. We have met with our clinical leads and our new lead for paediatrics and HSE, as well as primary care and all the other relevant clinical leads in our organisation, at what appears to be quite a complicated set of advice and very nuanced. It's not just an age group we're talking about, it's a different type of advice, a different grade of advice, and not just Fergal to directly to that pertains to an individual such as those who have underlying conditions, but it pertains to individuals who are otherwise well, who are live with or in contact with others who are perhaps more compromised. So it's going to take. We need to address not just where these should be given and where best given, but also in the communications. And the communications will be directed, of course, at parents, giving them all the information they need to provide them with the information to make decisions, and of course, the healthcare professionals who come in contact with children and parents to help them in providing advice on the ground at the front line, which is where the best advice can take place. But we've been working on that for some time, and since we got the advice yesterday, we've been working around the clock in seeing how we can translate this into something simple and effective. What is quite a complicated message, into something simple and effective, so that parents can make the right decision for their children.
Quick points to what the guys said. We know it's going to be extremely difficult to identify those that NIAC have highly recommended in the 5 to 11-year-olds. So that's a difficult identification purpose. And secondly, as I said in my opening remarks, we want to manage this programme that we don't lose pace overall, both within the 5 to 11 years overall, but also in the wider population that we're vaccinating too. So difficult to identify. We know we need some dedicated centres for it. And equally, we don't want to lose pace overall across the board.
Zara King, Virgin Media. Just want to follow up on Fergal's question there, because I suppose he makes a valid point in a sense that it's been over a week since we've had the first confirmed case. We were told the capacity is to hold genome sequence around 1,500 cases a week. So how many did we do in the last 7 days?
In short, I don't know the exact number. I know we have capacity, but I spoke to Killian de Gascon this morning. They'll be meeting through a group that Damien will be familiar with to see how they can raise capacity. That capacity we have, as it corresponds to the number of cases we have, has the ability to identify numbers of cases at 1% of cases, or new variants at the rate of 1% of new cases. But they're planning to expand further to upwards of 2,000 and more. From 1,500, which will be above the recommended level as set by the ECDC, but recognising that we need to have a comfort zone of whole genomic sequencing capability.
So if we're planning to expand, does that mean we're already using the 1,500 at the moment, then to say that we need more?
I can't answer exactly, but I know but we're going beyond our existing maximum capacity, and that's something that came through Killian's group, and that will presumably be implemented in the very near future.
I suppose people will just wonder though, Colin, like if we're looking at 1,500 samples a week and we don't have any new confirmed cases, that's possibly reassuring, or is it that it's just not picking it up?
I've no doubt there will be further cases, no doubt. This is a highly transmissible variant from our experience in South Africa. The slide showed how quickly the fourth surge has taken off in South Africa, much quicker than the first 3 surges. There is a marker for this, but it's not absolutely specific. That's the S gene dropout. And at this point in time, quite a number of S gene dropouts are being investigated and being sequenced. And I've no doubt many of those will be confirmed as Omicron cases.
No reassurance can be taken now with the low levels that we've identified here. We've seen what's happening in the UK. We expect it's only a matter of time before we are looking at significant numbers of cases of Omicron. We expect it to become more dominant. The time frame is unknown, but that's the uncertainty that we have right now.
I suppose it is just, we know that the whole genome sequencing takes about 2 days, and it's been 7 days since we've had a confirmed case. So it just feels a little bit unusual that we haven't had anything else come through, and there's so much work going on.
There will be more cases. And many of those that are being investigated for S gene dropout will convert, many if not most of them will convert to Omicron cases.
Yeah, just in relation to as well, I suppose I know you touched on it there, just the rollout for the 5 to 11-year-olds. Sorry, to be clear, so it'll be likely to be the new year, you think, in January then?
Predominantly, we'll be starting the 5 to 11-year-olds in January. We're just working through in terms of delivery schedules, but also the channels that we'll work through for the vaccination programme, and looking at some of those complex identified prioritised cases by NIAC.
I know the booster rollout is linked to obviously age and priority groups across the board, but I suppose in the last week in particular, we have heard a lot from people who got the Janssen vaccine who are really starting to get quite worried, particularly younger people who've had that 1-dose Janssen vaccine. They're well past the 3-month mark as recommended by NIAC. Is there going to be any move towards bringing those people up the pecking order in terms of getting access to a booster quicker?
It's good questions. The NIAC advice reflects the more rapid waning antibody immunity, the immunity as surface antibody waning in the Janssen category, so that in the 50s plus, the booster was given, is authorised to be given at an earlier interval as 3 months compared to the 5 months for others. And when we go below the 50s age group, those who receive the Janssen are afforded the same risk as those between 30 and 39. So there is some reflection in the relative risk profile of Janssen recipients in terms of lifting them up in the below 50s to a higher age than they would have if they were categorised based on age alone. So that's reflected in NIAC advice, and we'll be trying to translate that into the way we work.
Thanks. Simon Carswell with the Irish Times. Damien, how many vaccinators would you have working for you at the moment across the various vaccination centres?
Yeah, so I suppose the capacity within the vaccination centres at the moment is around 160,000. In terms of numbers of people, it'll run, in terms of actual people, it'll run into probably well over between 1,000 and 2,000. But many of those will be part-time, a mixture, Simon, in terms of hours. But our capacity at the moment is over 160,000, and we're aiming to bring that up over 200,000 starting into January. It isn't really an issue for us at the moment in terms of what we're getting through. As I say, with 270,000 in total last week across all channels. So we're trying to increase the pharmacy side alongside the vaccination centres, and GPs are a steady capacity in terms of what they're doing each week.
1,000 to 2,000 vaccinators. What would that compare with peak when we were doing it during the summer, the height of the summer?
I suppose we'd have had more in the summer in terms of just for a number of weeks at our peak where we reassigned people from hospitals. We've talked about this before. I suppose we're in a different place with our health service compared to where we were back in the peak of the summer. So there was a very short period where we would have had increased numbers, but typically we were running in around that sort of 200 to 250k period, or lower indeed in some weeks, depending again on the groups we were dealing with and so on. So I suppose the one big fundamental difference now is that we're still recruiting vaccinators in, Simon, and we're still working to increase the workforce. At this point, it isn't a constraint for us in any way. We lots of capacity there in terms of utilising it, and hence the reason I suppose we're trying to stimulate it with walk-ins and other ways. The UCD's example, a good one. I know there were other issues in terms of people having to not being able to get through, but they practically 75% increase in terms of their normal morning time work. Paul said it earlier, just to say, we know that people are busier. We know there's a lot more going on. We know that people are looking to get appointments that suit themselves. People are working, children in school and so on. And maybe in the summertime or, through the early part of the primary vaccination programme, we were in a different place as a society. So I suppose all we're really doing is A, trying to just stimulate it that people might take the appointment if it's there, but B, if that doesn't suit them and there's no way they can adjust, that the walk-ins are there. And we saw that this morning with the numbers that turned up, not just in UCD, but throughout the country. The waiting times weren't as excessive in other areas, but we had really good take-up now this morning, and that has been an issue for us, not just indeed in vaccination centres. It's feedback we've had from general practice as well.
Has there been a shortage in any way? You're saying capacity is not a problem, but has there been any shortage with medical students who would have been vaccinating during the summer, maybe gone back to college now that they're not available?
Yeah, well, clearly two groups we used before were students. We still use students. Students are still brilliant. They're coming in and working with us at weekends and evenings and giving us shifts, so that's great. And also the other group, as I say, we would have a lot of our own staff who were reassigned in the summer. And clearly the pressures in our healthcare system at the moment, we know we have a lot of people out with COVID. We also know we need more nurses in our hospitals. We have challenges in terms of other services as well. Our home care and primary care are under pressure. So we're in a different situation in that sense, and hence we're trying to continue our recruitment, but through other sources. And I would like to acknowledge the retired healthcare staff who've come back in and who continue to work with the programme. We've had a really good return to work, for want of a better word, from people who worked with us previously, worked in the primary campaign and have come back through again. We're also using some of the private sector as well, and they're supporting us. So we're using all possible opportunities, but at the moment it isn't a constraint, but clearly we're trying to continue to build it up, Simon, so that we have the maximum capacity available alongside the other two channels we have with general practice and pharmacy.
Just on the vaccination centres, would you consider running them for longer hours? The one in UCD today was quite short, even running well into evenings to try and capture more people so they can facilitate that. Paul had said that obviously with the Omicron is expected to become dominant. We know the benefits of getting the 3 doses. Does it not suggest that we should be ramping up boosters through vaccination centres in a huge way?
Yeah, well, we are. Many of them do run for longer hours. Obviously, this morning, the other thing that people have to accommodate is, say, the medically vulnerable, who are also being done largely on an appointment-based system at the moment. They can turn up for any walk-in if they're in a condition to do so, but we're really conscious of people perhaps who are ill and vulnerable. So they are run primarily through appointment-based systems at the moment, or indeed, they're also being done through general practice. GPs are calling their own, and again, people have an option on pharmacy. So, we have to balance off the appointments alongside the walk-ins, and clearly we will look to have longer walk-ins clinics to deal with some of the issues that came up this morning, and many of the centres that are running today are running longer walk-ins as well. So we'll continue to adjust the model, I suppose, Simon, as we go, with the balance between appointments and walk-ins, and also in terms of the timing. But we do have to accommodate a number of groups at the same time, and that is different to the summer in the primary campaign. The eligibility being another factor here as well that we have to weave in, that makes the scheduling process more complex, I guess, than it was with the primary campaign.
Just very briefly on the piece about trying to get people through quicker related to the Omicron threat. That's exactly what we're trying to do, and that's why I was drawing the comparison, and Damien has done it again. There are multiple channels now which people can come forward. We're working through the ages in blocks of 10 years, so 50s to 59s, all coming forward together. So very different processes at this time versus the last time. It's not actually like for like. You can only go to a vaccination centre, which primarily occurred the last time. The last time pharmacies were primarily just doing one vaccine type, Janssen. This time they're doing it for all ages. So very different operating model.
Just a last question from me. Paul, you'd mentioned there in relation to suggesting maybe that people are holding out for a better vaccine to deal with Omicron. Like, where you're finding cases of people being reluctant or that lack of urgency that the Taoiseach talked about earlier in the week, why is that? Have we kind of interrogated that more as to why people may not be coming forward? Is it because they've seen the 2 doses, and even with 2 doses, you're not protected to the degree that you once thought you were?
I don't think it's any one single factor. There's multiple factors what we're experiencing. So firstly, people are busy. People are back at work. They may be putting the appointment off. I have an appointment, but actually I'm going to see my GP in 2 weeks' time, or my pharmacy said they will do me next week. So that's one factor where people, it's not that race in, people are looking at options. Secondly, just that issue around, waiting for another vaccine type, and many of the pharmaceutical companies have been talking about developing another vaccine type for another variant. But all the evidence is your best levels of protections are coming forward now and getting vaccinated. So it's a combination of, there's different channels open. People have high demands as they're coming to Christmas. People are much busier than they were probably at previous times in the year. And, certainly we want to send a strong message. Our best protection is coming forward now and getting this booster to protect you against Omicron.
Cayman Burke, the journal.ie. So I'm just wondering if you could give me a little bit more information about the link up between the 3 different channels for the booster system. When did the text system go live? And is it expected, the new text system you introduced, is it expected that will resolve the issue with double booking?
So a couple of points. So the pharmacy system, essentially, the pharmacists use a system called PharmVax, which puts the information in real time, and that comes straight into the central vaccination system, and that will cancel any future appointments or prevent further appointments. So it's a real-time system that's in place, just to clarify that. There is no issues in that system. It's functioning well. The only thing that can happen from time to time, I suppose, if someone's working offline, it's go to update from when the records come through. General practice run their own practice systems, and there's an interface that feeds back typically nightly, and that feeds through. So it's updated usually 24 hours in arrears, maybe a little bit longer if a practice is under pressure. or whatever it is. But again, that feeds into the central system, and that will automatically deactivate any future appointments or prevent any future appointments. So that process has been in place for some time and is working well, and we've reconfirmed that in light of all of the concerns that have been raised over the last number of days on that. Then separately to that, in terms of the vaccination appointments that are issued, there were issues around, we know that with the texting system from time to time, different things. But the reassurance, I suppose I would say to people, and people were being conscientious in trying to cancel an appointment because they'd been vaccinated maybe in the other channel. If that record hadn't come through, they were contacting us, and we know there were some issues there. The improvements we've made have addressed some of those older issues that were there, but also introduced another opportunity for people, which is that if I was COVID positive, and there's been big numbers in recent times, of course, in terms of COVID positive cases, a person can text back with the word COVID. It's in the text that they receive, and that will ensure then that their appointment is deferred for a period, and they'll be prompted again then in about 6 weeks' time to see whether they're in a position then to take the vaccine at that point, and they remain on that prompting list. So we've made further enhancements, I suppose, to try and improve the whole communication. This is more complex, not just because we have pharmacies, GPs and vaccination centres working. We have the eligibility criteria. We have a larger number of people who are COVID positive than was the case, say, in the primary campaign. And all of those things have to be factored into it. But just to be really clear, the GP interface works daily. It works well. There may be lags from time to time. Primary care is under pressure. Pharmacy is a real-time solution, and that's working well. And we've confirmed that with the relevant bodies again this morning.
So when did the 3-option text message, when was that introduced?
Sorry, I'm not sure, just in terms of the 3-option text message. Oh, sorry, you're talking about the option to take a new appointment, to reject. The new option has been there since the very start. That worked through the whole primary campaign. That's worked well, where people could just text back new when they get a new appointment. The reject was added in then in terms of at a later stage over recent weeks with one of the upgrades to the system. And then last night there was another upgrade that brought in the COVID option.
And is it expected that now that will iron out those issues regarding double bookings?
In terms of the texting, there will always be time lags, though, in terms of the time when someone could be in a GP. But what I would say to people is we will get the information through. So even if someone gets a text, we overbook to allow for that in some ways. That's one of the reasons we do an overbooking, similar to an airline, in order we know there will always be an element of that. We'll never completely eliminate it. But the systems now are as aligned really as they can be. And it's really just down to timing issues that may cause that to happen from time to time.
So at this stage, it's a few weeks since the issues of no-shows was brought up. Do we have any idea what percentage is down to like system errors or system difficulties or teething problems, and what's down to lack of interest or people who aren't motivated to get a booster?
Yeah, I think I wouldn't use the word lack of interest. I know you're just given as an example. I suppose the research is still saying that ultimately the majority of people do want to get boosted. The feedback we have both in vaccine centres and indeed in general practice, which have been the two dominant people vaccinating, is it is a timing thing. People are under more pressure. They're looking to swap out appointments. And what we're really trying to provoke now at the moment is a discussion in terms of trying to increase that, and hence the use of walk-ins. So it's too early to say, like we've seen this morning, really good uptake around the country on the walk-ins. So that would give us more numbers through, more people vaccinated. That's really good. And we'll try and, I suppose, improve that process as best we can to make it as easy as possible. But it will mean with walk-ins that you will have queues. I mean, it's inevitable. And what we'll try and do is minimize that. And if you look at our social media channels, they're giving updates all the time in relation to the position in different walk-in clinics around the country. So people perhaps can see that and make a judgment whether they go to one clinic or another, or perhaps even defer to another day.
Sorry, just finally from me, yeah, Mr. Reid gave a very good explanation of why there might be people not turning up, or there might be a little bit of people not rushing out to get their booster. But what level of concern is there in the HSE about this at the moment?
No, I think from what we've seen over the past week in particular, and we kind of knew once we start getting into the ages, so 50s up, the first groups we've been doing have all been more complex, so long-term care facilities, over 80s, over 70s. As we move down through the ages, we've always been confident we'll see a strong demand push factor coming forward. And that's exactly what we've seen even today. And certainly for the 60s to 69-year-olds, it was a bit more difficult because only a smaller percentage of those in the first couple of weeks were eligible, because a lot of those would have been done in less than 5 months. So there was some complexity about it. But I would never put any of this down to hesitancy at all. We are not seeing vaccine hesitancy. On the contrary, but what we are seeing is multiple channels, people with multiple options, trying to fit that into their lives and the other demands they have. But our call would be to people, this is the most important appointment you can make between now and Christmas, or between now and New Year, or at any time. Please prioritise this appointment above anything else you might do for your own protection.
Paul O'Donoghue from News Talk. I think perhaps maybe one for yourself, Dr. Henry. You were talking about unvaccinated versus vaccinated in terms of how likely they are to contract the virus. Is just to kind of make that a bit clearer for people, I suppose, how likely is a vaccinated person to contract COVID versus an unvaccinated person, and how likely are the two groups to transmit the virus?
Vaccination affords maximum protection against serious illness. So we know that vaccinated individuals are much less likely to be hospitalised or go into ICU than unvaccinated individuals. I quoted earlier that despite that people who have when you look at illness, the people who are unvaccinated are only 13% of total positive cases, but they're 46% of ICU admissions. So what's weaker is with waning immunity is acquisition of the virus. So what's clear is people can acquire the virus, but they're still afforded some protection from the vaccine, notwithstanding the waning immunity from serious illness. For unvaccinated individuals, they have neither protection against acquisition of the virus, being infected, that is to say, or against becoming seriously ill should they become infected. So they're doubly exposed. One is they're more likely to be infected, even though vaccinated individuals have waning immunity against infection, but unvaccinated people have no immunity against infection. And secondly, should they become infected, they're much more likely to become sick, be hospitalised and go to ICU than individuals who are vaccinated, who, even though there's some evidence of waning immunity, have residual protection against serious illness and being vaccinated. So there is, and that's the purpose of the booster campaign, is to address the waning immunity and prevent not just hospitalisation, ICU, but infection in the first place among people who receive the booster, and to address that issue of waning immunity, particularly in those vulnerable groups. But unvaccinated people have no protection against infection or against the illness from infection.
You'd say that unvaccinated are more likely to be infected. How much more? Like 2 times likely, 10 times more likely?
I can't quantify that now, but certainly transmission, while a vaccination doesn't completely prevent transmission, we know that prevent acquisition or infection from the virus. People who are unvaccinated have no protection whatsoever.
Then I suppose just kind of the other question, I think, Paul, you touched on it, saying that public health measures are going to continue to be needed for the next while anyway. I suppose, how long do you envisage those public health measures like that social distancing and the restrictions that we have in place at the minute? How long do you think they will be needed for? Is it the type of thing we're working until the end of the booster campaign, or how long do you envisage that going on?
Well, we've always been clear from here, from the HSE perspective, that they're policy decisions for government. They'll be advised by public health experts, they'll be advised by NEFIT and the CMO, and we'll execute based on that. But what we do know is the actions that public have taken over the past few weeks. We can see it. People are cancelling bigger events. People are being more conscious of many that have indoors or what indoor events they're going to. And we can see, and we have seen the benefit of that, particularly in terms of hospitalisations. So ultimately, how long those are needed for would be guided by the NEFIT advice to government and government decisions. But from our perspective, at this minute and point in time, they are needed and they are working.
And I suppose like that, as you're saying, obviously it is at the end of the day, obviously it's a government decision, but yourselves and the HSE are clearly saying they're needed now. So under what scenario would they not be needed? Do you know what I mean?
Well, from our perspective, the public health measures are not just about restrictions. Public health measures about social distancing, wearing your mask, ventilation, protections for yourself. And honestly, they're going to be needed for a sustained and long period of time. We don't see people not needing to wear a mask and not needing to keep social distancing for some time to come. The wider issues around restrictions or government restrictions are exactly what they are, matters for government. But we see the issue of having to embrace public health measures. They really work and they're going to be needed and sustained.
I suppose just the final thing on that. So when you say some time to come, so say, for example, for social distancing, how long is some time to come? Is that a couple of months? Is that a couple of years?
The reality of it is we cannot predict, what may happen in the next 6 weeks. Right now, we've an uncertainty around Omicron. We have an uncertainty around even the Delta variant, where we're at the minute. We're at a high level. We can't predict too far beyond that, and their matter is really for where this pandemic goes over the coming next year. So there'll be greater experts than us in the HSE to, maybe predict on that.
Hello, Craig Hughes from the Irish Daily Mail. Damien, can you give a guarantee really that we won't have the same scenes that we saw this morning being repeated? And I know you mentioned earlier you've been trying to give updates on social media and things like that, but is that perhaps a mistake with the cohort of people that are being vaccinated at the moment who may not be on social media all the time to check if there's a long queue?
Yeah, I suppose we'll work to minimise it. I don't think anyone can give guarantee in terms of demand. What we'll do is work to minimise that in terms of trying to balance the appointment-based system with the walk-ins. As I mentioned earlier, Craig, our focus is on trying to improve the uptake. We're doing well in European terms, very well in European terms. We've been doing well in recent weeks, but we can see coming into Christmas it could get more challenging. And that's why we want to offer that alternative around the walk-in. And as I say, I think of the 22 walk-in clinics that have been held today, in general, the flow through has been pretty good. So we'll try and balance that off in terms of trying to ensure we minimise that for people, keep the communication going to people so they can see where there's pressure in a particular walk-in clinic, and then at least they're able to make a decision about whether they go on that day or look at an alternative clinic that might be close to them as well.
Thank you. Just on the IT system, can you explain what's different now than in the initial vaccine rollout? And I'm not talking about the different, like I know Paul had said here, obviously there's different channels, but purely with the IT system, I mean, you mentioned earlier that there was a glitch. Am I right in my understanding that it was simply a delay in inputting data into the system, or is there anything further than that? And finally, just on that point as well, has there been a reduction in the number of licenses you're using with Salesforce or anything like that would perhaps slow that down, that would perhaps limit the amount of people who are uploading the data into the system?
Question just first now about Damien. None of us said there was an IT glitch. Nobody from the HSE said there was an IT glitch. Just in terms of how it was reported, but we didn't. And I think Damien's clarified in terms of the system that is there and has provided real-time information from pharmacy and generally uptime information from GPs is still the same as well now as it was then. I just want to come to your last part of your question in terms of Salesforce expertise. No, we are still very high levels and continue demanding levels on Salesforce expertise to work with us in terms of the system. We've had 70 sprints, we call them, with various releases. And I've worked with technology all my life. I challenge any enterprise organisation that has deployed 70 very complex changes in parallel with keeping the system running and the vaccination programme going. So there's been 17 changes to the system based on the various NIACS advices. We've had the same level of Salesforce resource and supports, in fact, probably enhanced since we started. And the system deployment is still the same functionality at a general level as it did have throughout the programme.
Same with IBM, Paul. Is there any reduction in the IBM?
No, it's an IBM Salesforce partnership, so its resources are combined, Craig.
And there's no drop in the number of users, Craig. I mean, there isn't a constraint. I suppose we see how important the system is, and whatever it takes to keep it working and moving, we'll invest in that to do so. In terms of any changes, if anything, all we've been doing is introducing new pieces I mentioned earlier in relation to the option for those who were COVID positive that came in the recent release that Paul referred to, all of the different releases, so that those people can identify themselves, because they would also be people that would have to deselect themselves because they know they've had COVID in the last 6 months and hence can't take the vaccine. So that's a new feature that will hopefully help improve things for those people. They'll be able to flag it and we'll keep coming back to them and prompting them. And obviously they can choose themselves when their 6 months is up to maybe go to a pharmacy or whatever else as well.
With double bookings was simply because of with GPs and a kind of a lag. I'm just to clarify.
Well, yeah, there would be timing issues, and then also in terms of various issues in centres around appointments. But broadly speaking, the system from the GP and pharmacy side is coming in, as I say, real time for pharmacy and on a daily basis. Usually, it can vary a little in terms of each practice, as I say, based on the pressures they're under.
Colm, you said earlier that 13% of the total cases are unvaccinated. Does that include children or is it just adults? And is there any breakdown of the case number or the percentage case numbers in children?
No, it's the total number of cases. So obviously we're addressing that but our concern is, to get to the point I was trying to make, is how exposed, particularly those older unvaccinated, because we know, fortunately, for children, serious illness and hospitalisation is relatively uncommon. But for older people and those with underlying conditions, being unvaccinated, they have no protection.
And just finally from me, I think it's probably for Damien, Roisin Shorthall said today that some cubicles are not open in vaccination centres. I mean, is that because the demand isn't there or for staffing issues?
Well, just in terms of, I think the comment might have been, was it in relation to UCD, who are now they're operating at their full boots today? Like each centre will judge it daily based on what they think is coming in the door, what they operate on a given day. But I mean, certainly in terms of whatever booths need to be opened, the centres are opening. They make those decisions locally, Craig, each day in terms of what they think the demand will be based on the mix of appointments and walk-ins. You're not constrained? No, I mean, at the moment it isn't an issue for us. So the physical capacity is mapped out, and they will decide locally on a given day in terms of their scheduling what they need to operate with on any day. You know, and they can always peak it up or drop it back depending on what they think is going to come in. You know, and also in terms of timing within reason over a day.
Hi, Niamh Griffin from the Irish Examiner. Could I just ask, in terms of the hospitals, we've had a few reports this week about long waits at emergency departments. What's being done this week in terms of the supports you were mentioning last week for the emergency departments especially?
Yeah, it's been a range of supports put in, not just on the emergency departments, Niamh, but also as part of our winter plan. So we've strengthened the investment in GP access to diagnostics. So that has certainly taken a huge uptake over the past week in particular. In terms of flow through of our hospitals, we've also much greater increased our utilisation of private hospitals. So last week alone, we'd almost 1,700 bed days utilised with the private hospital groups, and that was only about 1,100 just a couple of weeks ago. And so we're increasing our capacity through there. We've put more resources into home care and community intervention teams to give greater care outside of the hospital system. As I did mention in my opening remarks, we have seen extremely high presentations of over 75s into emergency departments, and also in terms of admissions. And we do know in terms of over 75s, generally we have about 25% admissions from ED. Over 75s would be 50% admissions. So that's been a concerning factor, and it's much higher than 2019. The equivalent week in 2019, when in 2019 we were dealing with a peak season of flu. So that is a concern for us, and we're looking at what other supports we can enhance in the community to reduce, particularly elderly people having to come to emergency departments.
Okay, and are people saying why they think that is? I mean, is this still a hangover from the lockdowns, that people are more ill, more frail than they should be?
Well, certainly what we have seen, even throughout and after lockdowns, we've always seen higher levels of presentations from elderly people coming forwards. Sometimes it has been care neglected throughout various periods of restrictions. And that's been a kind of trend we've seen, not just over the past couple of weeks, and not just in many cases just with elderly people, but other people who may have neglected care at various points in time. But look, we're heading into a high respiratory illness season, and that's a factor too as well.
Okay, and just on the children, Colm, in terms of the dosage, we've had a few queries from parents who are worried that little 5-year-olds are getting the same dose as 11-year-olds, that apparently medication would usually be a bit more staggered. Could you maybe go through that, the safety elements of the vaccine for children?
You may have approved the vaccine at the reduced dose for children, and that's been verified by NIAC, but we're going through all this information that we will be putting together for parents to make sure and that will include information on safety for children and information on the dosing. So that's part of the work that's ongoing, and behind the meeting with clinical leads today and led by Lucy Jessup from the NIO. So we will be providing all that information to parents.
Okay, thank you. And yeah, there was one. Oh, yeah, just on the promotion that you're going to be doing, maybe Damien, for the vaccine for children, is that going to be done in multiple languages? Again, there was a lot of concerns about the vaccine information for pregnant women, that it wasn't available to migrant groups early enough.
Yeah, so I suppose, as you know, in the primary campaign, we've done across our whole range of languages, between 20 and 30 for different pieces of information. So we'll do that again in terms of children also, yeah.
Yeah, Zara again from Virgin Media. Last week I was speaking with Professor Salim Abdul Karim. He's an epidemiologist in South Africa. He was a former co-chair of their Ministerial Advisory Committee on COVID-19. Really interesting to hear his outside perspective on what's happening here and also in South Africa in terms of Omicron. So clearly their vaccination rate, they've about 35% fully vaccinated. We're obviously near the 94%. So he was very impressed, obviously, with our vaccine levels. But he was also equally shocked that we're in the region of 5,000 cases a day. And he found that kind of difficult to comprehend based on our population. He said the doubling time for them was that cases were doubling every 1.5 days with Omicron. I suppose, Damien, realistically, if testing is almost at full capacity, it's, tipping above sort of surge at the moment. Will we realistically even be able to count those cases when that time comes for us, or if it comes for us, if we find ourselves in a situation where we're getting to the 10,000, 15,000 cases a day? Are we sort of getting into a space where we can't even collate the data because we won't have the capacity to actually test those people?
So I suppose I said earlier, we're building up, Sarah, by the end of the year to over 250,000, and we're obviously at all times we have sort of what we call surge contingency planning. So we look at what those opportunities are, and we work with the Department of Health and NEFID in that. Again, the core message, of course, here is always important, and I know people, we don't always want to hear it, but the core message, if you have symptoms, of course, is until those symptoms have abated and you're symptom-free for 48 hours, then, the test in some way is just an indication on that. So I suppose the public health guidance will always apply irrespective of demands, and Colin might want to comment on that. So we are always looking at options in terms, but clearly there's a ceiling, there's always a ceiling. We're at 250,000 at the end of the year. We always thought 100,000 was the gold standard. And, that's since August. So there's been a huge jump, more than doubling of the capacity, particularly over the last couple of months. And there will be a limit that we'll get to, Zara, in that sense around it. But again, the public health guidance will apply in whatever scenarios we face into. But we continue to work with, colleagues in the department to look at what those scenarios may be and what adjustments to the testing strategy can be made in the event that those situations were to arise. So Colin may want to comment as well. But
There's always a caution, by the way, in terms of comparison of cases, what's the testing capacity? I'm not talking about South Africa in particular, but we found that by comparisons with Europe, what level of testing they might be at, what cases they're showing, proportion of population. So it's not always like for like comparisons.
And the other points are, even the ECDC figures, some countries use, if the antigen tests they're in there, so you have to look at it in terms of PCR capacity clearly, which is the primary test in relation to, the actual symptomatic people.
How are we doing? Anyone else? No? Niamh, one more thing.
The vaccine rollout as well. There's some families now where you might have an immunocompromised adult, say the mother, and then the child is going to get vaccinated now, but the mother's partner is not yet, maybe in their 30s or something, not getting the booster. Is there any leeway for GPs to vaccinate everybody in the family, to give a booster, earlier to other people?
Well, there is a difference there in the child is completely unvaccinated and the partner is vaccinated but awaiting a booster. So there's a difference in risk to the immunocompromised individual in the house, the mother in this case. So the priority is to address the unvaccinated household member, namely the child, provided, of course, the parents' consent in order to afford protection. That's the priority over providing the booster to the other individual who we'd like to see get the booster too in due course.
That's it. Thank you very much. See you next week.